Hello everyone, my name is Swati Babar. I'm an occupational therapist working in Austin, Texas. Today I will present my evidence-based practice project where I will compare the effectiveness of supervised therapy to home-based instruction in patients with neurological disorders receiving outpatient rehabilitation. So here's a little bit about me. I got my bachelor's degree in occupational therapy from the Institute for the Physically Handicapped in New Delhi, India in 1997. I've been a practicing OT for more than 20 years in the US. And during this time, I have worked in various settings like hospitals, long-term acute cares, inpatient rehabilitation, skilled nursing facilities, and home health. I currently divide my practice between two facilities. One is a rural outpatient setting and the other is a community hospital. My project today is based on my practice in the outpatient setting. So what is occupational therapy and what does an OT do in an outpatient setting? AOTA states that occupational therapy assists individuals achieve health, well-being, and participation in life through engagement in occupations, that is, activities of daily living. In outpatient, we see some orthopedic patients like post-upper extremity fractures or chronic conditions like tendinitis. On the neurological side, we see adults with stroke, ALS, and Parkinson's, etc. OTs in an outpatient setting work with the client's coordination, upper extremity range of motion, and strength, improve their ability to perform ADLs, which typically as outpatients is mostly IADLs like cooking or driving. We also assist clients to develop skills to resume their work or leisure activities which are meaningful to the client. Now, this can be different for each person. For some, it may be cooking. For others, it may be woodwork, whatever is meaningful to them. So here's how I'm going to proceed with my presentation today. I will first describe the problem that I'm seeking an answer for, the evidence found by searching the literature, describe my practice recommendation, then talk about the process of implementing the change, and finally, share my thoughts on the dissemination of this information at local, regional, and national levels. A 2016 study by Amico, Meadow, and West of Medicare claims data reported a total of 4.8 million outpatient rehabilitation episodes. 15% of these required occupational therapy. Although this is a significant number, it is not always possible for the patients to obtain rehab in a therapy clinic. Sometimes it is patient preference to get therapy at home, or there are cost or insurance issues. At other times, patients do not want a long commute to the clinic. This brings me to my practice problem. My clinic is located in a rural site and I have patients traveling from different parts of the region to get therapy. And so lots of times the patients ask me to give all the exercises when I evaluate them so they do not have to commute frequently to the clinic. Also, sometimes there are cost-related or insurance coverage-related concerns, so the patients prefer to do the exercises at home. I try to accommodate this request of theirs as much as possible, but I often wonder if home exercise program was as effective as the therapy in the clinic, which was my practice problem. This problem led me to my PICO question, which is, in patients with neurological diagnoses requiring outpatient rehabilitation, is supervised therapy more effective than home-based therapy in improving functional and quality of life outcomes over a 6 months period? To find evidence for this, I conducted a literature search. I primarily used the search engines of Search USA and Google Scholar to research this. Simultaneously, databases of PubMed and CINAHL were also researched. The Search USA engine retrieved articles from other databases also, like EBSCOhost, Science Direct, Ovid, and CINAHL Complete. Keywords used in the search were supervised therapy or therapist supervised, home-based instruction, or home exercise. Other terms which were used were rehabilitation, stroke, and neurodegenerative diseases. This was done to narrow down the number of relevant articles in a particular database. The inclusion criteria was adults over 18, peer-reviewed journals, articles in English about patients with neurological conditions from 2004 to 2019, pediatric clients, and inpatients were excluded from the literature search. As you can see from my Prisma diagram, PubMed yielded 308 articles, Sonal Search generated 75, Search USA produced 235, and Google Scholar gave 1,030 results within the 2004 to 2019 timeframe. Due to time constraints, not all articles from Google Scholar could be screened. Therefore, search was limited to about first 10 pages or about first 200 articles. Titles and abstracts were the first line of screening, and full text was reviewed of only peer-reviewed articles. Finally, 8 articles were included for this project from 2004 to 2019 using Prisma search strategy. The search to find the evidence was narrowed down to 5 original quantitative research articles and a systematic review. The other articles listed in the references were sources of background information and data. 3 of these studies focused specifically on the comparison between supervised and home-based therapy provided to the patients with neurological diagnosis in outpatient setting. The article by Kara and Sia investigated the adherence to the home exercise program using 2 different types of protocols. 3 studies reported better patient outcomes with supervised therapy. 2 of those studies reported home-based therapy equally effective as supervised therapy, although the studies concluded that the supervised therapy was slightly better in self-reported outcomes. Both these studies also credited the effectiveness of home-based therapy due to improved adherence secondary to caregiver support. So the key findings of this synthesis were: supervised therapy programs in outpatients with neurological diagnoses show trends in greater improvements in functional and quality of life outcomes. Home-based therapy is an equally effective treatment tool, but its success depends on the adherence to the protocol. Adherence is greatly increased if there is good social support or caregiver involvement. So based on this synthesis, I formed a practice recommendation. All the reviewed articles were consistent in reporting the positive impact of supervised therapy. Majority of articles also found home-based therapy effective and a good alternative to therapist-supervised programs. However, they credited the success of home-based program on adherence to the program, which was better if the caregiver support was present. So I concluded that while supervised therapy is a more effective option for improving functional and quality of life outcomes in outpatients with neurological disorders, but if there are cost or transportation constraints, the therapist should investigate a patient's social support and then use his or her clinical expertise and make a decision in collaboration with patient to decide the best structure of therapy program. For example, the therapist can make a clinical judgment about the ability of patient to accurately run the exercises and may determine that this particular patient may need repetition to perform exercises accurately. He can then discuss this with the client and request him or her to try to attend a few sessions in the clinic to imbibe therapy techniques better, just to ensure better carryover. He can also emphasize the presence of caregiver in this particular conversation. The model I chose to implement a change is A-STAR model. A-STAR model by Stevens has 5 steps: knowledge discovery, evidence summary, translation into practice, integration into practice, and evaluation of outcomes. This was a model of choice for implementing change for my project. One of its steps, that is step 3, translation into practice, suggests using clinical expertise and to keep into account the individual factors that affect adoption of a recommendation. This aligned the most with my practice change recommendation and therefore was the most logical choice to me. I have talked about the first 3 steps in the presentation already. This step, or step 4, is implementing the change or integration into practice. For this, there will be a need to engage stakeholders. The key stakeholders for the EVP change for my project are the patients or patient representatives, department head or site manager, and frontline administrative staff. I plan to draft the proposed change for the stakeholders, which will include justification to make the change along with the synthesized research evidence of the literature reviewed, and present this by a PowerPoint presentation at our facility in one of the department meetings. If there is a buy-in, I will implement a pilot. The next step is the evaluation of change. This can be done by measurement of outcomes. If outcomes show improvement, this is an indicator that the pilot of the proposed change was successful. Supervised therapy is the independent variable in this project, and quality of life and functional outcomes are the dependent variables here. I propose two outcome measures, Human Activity Profile, HAP, and Short Form 36, SF36, to measure function and quality of life. SF36 and HAP are both questionnaires or surveys. The HAP is a survey of 94 activities listed in the order of increasing metabolic cost equivalent. The activities include self-care, transportation, home maintenance, entertainment or social, and physical exercises. The SF36 is a recommended measure of physical, mental health, and quality of life. Both are self-reported outcome measures and will generate non-parametric ordinal data. Outcomes will be measured at the start of care, 10 weeks, and at 6 months. HAP and SF36 will be administered to both groups, supervised and home therapy group. The office staff can provide these forms for the patient to fill. For statistical analysis, I plan to do a Mann-Whitney U test, as it is used for 2 treatment groups for analyzing ordinal data. If the statistics indicate that the change is successful, further dissemination can be done. At the institution level, I may present the results to the leadership team and discuss if there is a desire for this change to be implemented across other sites. If there is enough interest, I will hold a second meeting at a convenient location with the site managers of other sites as well as the leadership team. If a buy-in is anticipated, I may travel to other sites and educate other practitioners as needed. Locally, I think the knowledge of these results will be valid for anybody or any practitioner who works with outpatients with neurology. It can be social workers, family practitioners, OTs, PTs, PM&R physicians, and neurologists. Therefore, dissemination to all these local professionals can be done by providing a small informational brochure which includes the salient points of the presentation. This dissemination will be done assuming that these practitioners may act as reinforcers or supporters of OT recommendations. Regionally, I can present the findings in Texas OT Conference and nationally at AOTA Conference via a poster or PowerPoint presentation. At the national level, dissemination can also be done by publishing a paper in AJOT. To summarize it all, let's revisit my PICO question. What is better with outpatients with neurological conditions, supervised therapy or home-based? To answer my question, I did an extensive literature search and found 6 original research articles, synthesized the evidence obtained, and arrived at the answer. Here is what I found. Although face-to-face therapy in the clinic is the best way for the patients to achieve their maximum functional potential, there are several reasons it cannot be achieved. Long commute to the clinic to access therapy services, cost restraints, and patient choices are some of the reasons. In this situation, home-based instruction can be equally effective if the patients adhere to the program and the caregivers are involved. Therefore, I recommend for the therapist to use his or her clinical expertise and collaborate with the patient to decide the course of the therapy program and emphasize caregiver involvement. So, to sum it all up, patient preference should be the deciding factor of where the therapy is received, at home or at the clinic. Here is a list of my references. Does anyone have any questions? If not, well, thank you very much for listening to me today. I would also like to thank Dr. Anna Cohn, my go-to faculty, and Dr. Podlog and other IPE7050 instructors for your guidance throughout this course. Have a good day.